Now they're coming on.
Yeah.
All right, so we are live, everyone.
We're just waiting for everyone to come in. We'll get started in a minute. Okay. Yeah. 10 more seconds and we'll get started. Okay. Hi, everyone. I'm Julie Gertzey, an RN and founder of Rand New England. You may hear us refer to our organization as RNE. RNE is a nonprofit organization devoted to bringing education and information about rare diseases to all who touch the rare disease community. Welcome to RNE's Career Fair in Medical Genetics. We are grateful to everyone for being here tonight. When we hear the word rare, we think of a small number, but in reality, there are collectively 30 million people diagnosed in the United States and 350 million affected globally by a rare disease. Statistically, 80% of these rare disease patients have a genetic disorder. There are not enough geneticists to care for these patients, and this situation will only get worse as technology moves forward and patients are better and faster diagnosed. Remember, these patients are sick and not receiving appropriate help. While they wait, they are hurting and sometimes dying because others just don't understand what's wrong with them. Something must be done to help these families, and RNE is trying to make an effort in this area. Let me now introduce you to our host for tonight's event, Dr. Mark Korson. Dr. Korson is a pediatrician who specializes in metabolic genetics. He has directed the metabolic clinics at Children's Hospital and Tufts Medical Center in Boston. He is co-founder and co-director of the North American Metabolic Academy. Currently, he is director of the Physician Support Service and director of education at VMP Genetics. He is also a founding board member of Rand New England. A more complete biograph can be found on the Career Fair brochure sent to you. Through RNE, Dr. Korson has directed informational opportunities such as this Career Fair tonight in order to make a positive impact for all genetic disease stakeholders. Thank you, Mark. Take it away.
All right. Well, thanks, Julie. Thanks, everyone, for attending Rare New England's Career Fair. First, I want to thank the New England Regional Genetics Network for its generous sponsorship of the career fairs. As Julie said, I'm a pediatrician who is focusing on biochemical or metabolic genetics. So if you think back on your biochemistry, I'll deal with patients and families who have defects in those biochemical pathways. Now, biochemistry can be abstract and rather dry, but it is that patient community that really puts the human back in biochemistry and shows how relevant the urea cycle is, or the electron transport chain. Why are we doing this program tonight? Well, genetics impacts almost every area of medicine. So as you can imagine, there's a growing need for geneticists in this country and abroad. Patients and families want and need to hear information about the diseases they have, information to plan for their futures, information as a couple with a family history looking to have children, and information about effective therapies now available for genetic diseases. So that's a lot of information that needs to be shared. But the impact of genetics is not just in rare disease. Genetics can impact how we manifest lots of mainstream diseases, like COVID, how we respond to disease, how we utilize medications, what medications are available or effective or safe for us, and so on. So this evening, you will hear from 3 geneticists: a general clinical geneticist, a metabolic geneticist, and a research geneticist. You'll hear a bit about what they're doing, how their genetics expertise has helped to treat their patients and families, and how the experience has impacted their own lives. A Q&A session will follow the 3 presentations. Please submit your questions as we go in the Q&A area, not in the chat area. After that, I'll guide you through some additional opportunities to learn more about this subspecialty. But first, You might think that liking biochemistry makes me a nerd. And in fact, the fact that I bring some biochemistry into the clinic makes me even more of a nerd. Well, fun fact, I am a nerd, but we genetics nerds can have fun too. So let me show you how with this very interesting genetic pedigree. Many, many years ago, when I was 23, I was married to a widow who was pretty as can be. This widow had a grown-up daughter who had hair of red. My father fell in love with her, and soon they two were wed. This made my dad my son-in-law and really changed my life. Now, my daughter was my mother because she was my father's wife. To complicate the matter, even though it brought me joy, I soon became the father of a bouncing baby boy. My little baby then became a brother-in-law to dad, and so became my uncle, though it made me very sad. For if he was my uncle, then that also made him brother of the widow's grown-up daughter, who of course was my stepmother. Father's wife then had a son who kept him on the run, and he became my grandchild, for he was my daughter's son. My wife is now my mother's mother, and it makes me blue, because although she is my wife, she's my grandmother too. Now, if my wife is my grandmother, then I'm her grandchild, and every time I think of it, it nearly drives me wild, because now I have become the strangest case you ever saw. As husband of my grandmother, I am my own grandpa. Oh, I'm my own grandpa. I'm my own grandpa. It sounds funny, I know, but it really is so. I'm my own grandpa. Note that this was written in 1948. It exists in multiple forms on the internet, but I was the first to actually put a pedigree to it. So let me stop sharing. And now it gives me pleasure to introduce, our first speaker. I'm finding that. So Dr. Brian Skotko from Massachusetts General Hospital in Boston. A board-certified medical geneticist, Dr. Skotko is the Emma Campbell Endowed Chair on Down Syndrome at MGH. As director of the hospital's Down syndrome program, he has dedicated his professional energies toward children with cognitive and developmental disabilities. He co-authored the national award-winning books, Common Threads, Celebrating Life with Down Syndrome, and Fasten Your Seatbelt, a crash course on Down syndrome for brothers and sisters. He's a graduate of Duke University, Harvard Medical School, and Harvard Kennedy School, and he is currently an associate professor at Harvard Medical School. He's a leader on clinical and translational research about Down syndrome. He's been featured in the Wall Street Journal, the New York Times, Washington Post, the LA Times, NPR's On Point, and ABC's Good Morning America. Dr. Skotko has a sister with Down syndrome and serves on the honorary board of directors for the Massachusetts Down Syndrome Congress. Brian?
Mark, thank you so much. And it's really great to be here this evening virtually with all of you. And thank you for your budding interest in genetics. I just want to share a little bit about my life, but my take-home message is truly and honestly, the job that I have is a fulfilling one. And so many of us are so lucky to have careers built around purpose. And that really is what has been true from the moment I became a physician until now. So what I wanted to do is share a little bit about my pathway, and then just randomly, I am going to tell you what I did yesterday, just so you could see what does it look like in the day of me. And after medical school, I also wanted to pursue a master's in public policy because I knew I wanted to take care of people with cognitive and intellectual disabilities. So I got that extra degree. And then I went on to get my residency training in pediatrics and then did my fellowship in medical genetics. From there, I landed to become an attending at Massachusetts General Hospital, where I still practice today. And there I get to be the director of the Down syndrome program, which is a multidisciplinary clinic. And I'll tell you about that in a moment. But many of us have personal stories. I have one as well. As you heard Mark mentioned, I do have a sister with Down syndrome, and she certainly was the impetus for me to go to medical school. And one day I wanted to have a job where I would be able to take care of patients just like her. I'm lucky enough to have that, but along the way, I met so many other patients and their families that continue to light that fuel and keep my flame burning. So that's what brought me to medical genetics, again, having a family member, but also falling in love with all the patients and the training and having cool professors and great teachers and mentors along the way. But let me just give you a snapshot of what is it like to be a medical geneticist yesterday. So yesterday I woke up and I had clinic, and I not only am directing the Down syndrome program at MGH, but I get to actually practice and be a doctor. And we've built a multidisciplinary clinic, which many geneticists get to be a part of. And that means you get to practice not just by yourself, but you also get to see patients alongside with other interesting professions. So in our clinic, that means that we have patients rotate through a doctor, a social worker, a physical therapist, occupational therapist, speech therapist, audiologist, ophthalmologist, a resource specialist, and some other players. Now, if this was pre-COVID times, we would all be meeting in person at 7:30 to have our in-person huddle before we began clinic. But since it is COVID times, we've transitioned everything to virtual. So you can't beat the commute. So we all gather around our kitchen tables in our own homes, and we turn into Zoom, and we still have that huddle. So from 7:30 to 8, we quickly went through all the patients that we were going to see that morning, afternoon. And we quickly said, don't forget, we need to do this. This person needs labs. Don't forget, the mother asked this question last time, and this is what I want, and we need to get this form. And we quickly go around saying what we have. And then we saw 6 patients that morning in rapid fashion. I see all of my patients hand in hand with our team social worker. We work in pairs, and that's because of the social and the psychosocial questions sometimes are so indelibly entwined for patients with Down syndrome with their medical issues. So we have them tell their story once, and it's really fun to be able to see those patients. I also had a fellow that was following me, and I had a medical student that was following me. So even though we couldn't be in person, we were following through Zoom. So that was my morning. I got to cycle through and help 6 families. Now, in this particular case, it is a maintenance clinic. So I'm not making the diagnosis of Down syndrome. They ranged in age from early children all the way up to, I think I had a 24-year-old that I was seeing. But we are the doctors who work with the parents to provide that specialty level care. So we know that there is a playbook that goes along with the condition I love the most, Down syndrome. And I want to make sure that primary care physicians who may only have 1 or 2 patients with Down syndrome don't have the burden of having to remember all the details that go along with that particular condition. So we see a patient, and if a patient is having certain symptoms, oh, could this be obstructive sleep apnea and Down syndrome? What do we need to do? Oh, could this be celiac disease and Down syndrome? What do we need to do? How best do you teach math to people with Down syndrome? If someone with Down syndrome wants to get Social Security, how do they go about doing it? If they want to get a job, what are the possibilities within Massachusetts? So we've become just little niche experts on our particular syndrome, but it gives me great joy to be able to bring that kind of comprehensive care. So I am practicing genetics, but really in a multimodal, multi-system way, and not just diagnosing, because the diagnosis is behind us. So clinic was then done at noon, and then I broke from Zoom and I had lunch with my wife, who is also able to work from home, and we try to break from 12 to 12:30. Then it's right back on the computer. And from 12:30 to 1:30, I had a meeting with the local nonprofit organization that specializes in Down syndrome. I feel very strongly in partnering and working with our community-based partners. And we had a question that we needed to solve. And that is, what is the message that we're giving to our families about legal guardianship? So when all of us turn 18 in the state of Massachusetts, you become your own adult, right? But for people with intellectual disabilities and those with Down syndrome, sometimes they need extra protection. And there is a system you need to go through in our state's courts in order to have someone else continue to be your legal guardian. When is that the right thing to do? How do you do it? How do you go about doing it? Our clinic was giving one set of recommendations, and we realized that people in the community were hearing a slightly different message from our community-based partner. We know them well, so we got on a call together and we all kind of chatted it through. What are the facts? What are we hearing? How can we synergize? How can we better work together? And it's calls like that that I really like, because we're showing that as medical professionals, we get to work with our community nonprofit partners in order to deliver consistent and better care to our patients who seek information from so many sources. And then let me bring up my schedule. Then later on, I then had a research meeting. So half of my life is also to oversee our research portfolio of work that's going on. Our clinic just built a virtual Down syndrome clinic because we realized we're not going to be able to see everyone in our state, let alone everyone in the world. So we just finished a 3-year grant where we've been able to build a virtual clinic that's been launched. It's called Down Syndrome Clinic to You. If you want to check it out, what a geneticist can build online with a bunch of computer and software engineers, you could go to DSC, the number 2, the letter U.org. And it's there that I met with my research team to say, okay, how do we push this out? Who is signing up for it? How do we make sure we reach families who are non-white? Because what we want to do is build a product that democratizes healthcare for people with intellectual disabilities, particularly those with Down syndrome. We had calls about taxes. Do we need to charge taxes for those who use this product? How do we make sure we reach people that we recently talked to in Japan and Saudi Arabia? So it's been really fun kind of building that and putting that all together. Then I checked email because there's invariably email that you get throughout the day that adds up. Then I had a little time for patient results. We get patient results that come through, delivering the results of sleep study. Oh, this thyroid came back, calling back to parents. And then I ended my evening, I teach a course called the Patient Doctor Course #1 for first-year medical students at Harvard Medical School. And with a colleague of I have a class of 6 students where we reflect on the challenges, the rigors, the onuses of being a budding doctor. And I really enjoy teaching that class, and I had that opportunity to do that for an hour and a half. And then the day was done. And then I got to enjoy dinner with my wife. And then we went for our walk outside, came back, and I'm a big fan of doing crossword puzzles and reading. So I wound down my day by doing a little bit of a crossword puzzle and reading. So that is a day in a real geneticist life. And I'll end it there. And then thank you, Mark, for the opportunity to be here. And I'll look forward to answering some of your questions at the end.
All right, thank you so much, Brian. Terrific. On to Dr. Michelle Spencer-Manson from Yale New Haven Medical Center in New Haven, Connecticut. Dr. Spencer-Manson grew up in New England, eventually going to University of Massachusetts Medical School. She went to Duke for residency and fellowship training, where she completed general genetics residency and a medical biochemical genetics fellowship. She worked at Duke for a year after training and then came home to New England, yay, for a position on faculty at Yale, where she has been there for the past 6 years. Michelle, unmute.
All right, well, thank you guys so much for having me. I'm very excited to be talking to you all, and hope some of you guys are very excited about being a geneticist. It is certainly, when I was in your shoes, whether it was an undergrad or medical school, was actually not what I thought I would do. And it was actually a decision I made as a second-year medical student, or second-year resident, actually. Apologize. I'd actually started off medical school thinking I'd be a surgeon, and I did 2 years of surgical research and got to my surgical rotation, decided, yeah, no, particularly when I was getting up at 4 o'clock in the morning. And then I kind of oscillated between pediatrics and internal medicine, ultimately started in internal medicine, and then of all things, got a couple genetics patients, fell in love with it, never looked back, and have kind of been on this pathway to that ever since. So I did make a couple slides. So I'm going to share my screen with you guys and kind of walk you through a little bit why I think my job is the best job you could have, and hopefully answer some questions then maybe at the end. All right. Share. Okay. All right. So I hope everybody can see that okay. So basically I started this, kind of thinking clinical and biochemical genetics is. So I saw this kind of fun thing with it, like the top 10 reasons why you wanted to do something. So I kind of put my top 10 reasons why this is the job that I would pick all over again in spades if I had to make the same choices. So basically it's the coolest job ever. I'm not sure if it's quite as cool as being this dog or this baby, but outside of being the dog or the baby, it is the coolest job that I've ever had. I really love what I do. I know a lot of unhappy doctors out there. I am, don't get me wrong. I when I'm doing notes, there's occasionally time I'm crazy, but I'm not crazy about it. But in general, I get up, I like my job. I enjoy what I do. I always feel challenged. The job is always interesting and never routine, no matter, and this is one of the things, even as I was thinking about what I wanted to do, you'd be a cardiologist and it's really exciting. This is one of the things I considered, right? Like you're running in, you're taking care of heart attacks, you got a baby with congenital heart disease, you're kind of taking care of them at 2 o'clock in the morning to pick you, and it's all very exciting, right? But at some point you've done the same thing 100 times, 1,000 times, 2,000 times. In this job, and I've been doing it over 10 years now, I job is always interesting. I'm always seeing new things. It's never routine. I'm always looking stuff up. And I have bread and butter, and we do see repeats, but a lot of it is, it's always new. It's always fresh. New disorders are being discovered. So that's one of the things I love about it. And you can see here, like, there's so many things that fall under the blanket of genetic disorders. We see a wide range of disorders. I see every age. I will be one minute I'll be seeing this cute little baby, and I have patients that are in their 70s, right? And so that's, I think, amazing. And we see a wide range of abilities, right? I have children with profound developmental disability, moderate developmental disabilities. I have, kids who are going off to college, and law professors, and athletes, and people who are in wheelchairs. And I love the fact that I'm able to see a wide range of disorders, ages, diagnosis. So that's one of the things that's very appealing to me. This is probably my absolute favorite part of my job, is that I have long-term relationships with families. I cannot tell you how many pediatric families, as they hit this 18, 20, 21, 22 area, are starting to freak out, right? The cardiologist is transitioning, the pulmonologist is transitioning, their pediatrician is telling them they have to go. They're like, I don't want to leave, nobody wants to leave pediatrics. But we're there, we're their rock. We are the center of what they do. We never leave them. Right. And it basically, the only time they have to get upset is when we retire. And so I hope I got a few more years in me still. But I love the fact that I have the long range relationship with families, but I also see multiple family members. Like, there's a lot of places where I care for more than one child, or I'll care for a child and a parent and a grandparent and stuff. So you really almost become part of this kind of extended family for these patients. You interact with a wide range of specialists. So, a lot of times when you are doing any particular specialty, you'll interact with some people, but you get a little more pigeonholed. Genetics affects everything. Our patients have multiple different systems, and so for me, I do my, about half of my job is a biochemical geneticist. Like Dr. Corson, I take care of the inborn errors of metabolism. We get all like geeked out and excited about pathways and stuff like that. But another part of my job is I run the cardiomyopathy clinic now, a lot of with one of the cardiologists. So we have a joint clinic together. And again, a lot of those, particularly in children, they have an inborn error metabolism as part of that. I do the seizure disorder clinic. I do a neurogenetics clinic. I do a neuromuscular clinic. So all those things here, I get to interact with a lot of different specialties. I get to do clinics with other people. But, I would just say my last paper, the last major paper I got published was in the pediatric surgery seminars. And so I did a paper on biliary disorders that had a genetic cause with the surgeons, and kind of worked with them and learned all sorts of cool things, not just about the genetics of these kind of congenital malformations, but the surgical approach based on the genetics. So you get to do that. Pathologists, we have rounds with the pathologists, we'll have rounds with the radiologists. We work with the OB when the patients are pregnant and then we know a genetic disorder is coming. So basically the sky is the limit. You can focus and have a more narrow group. But I love the fact that I have like friends in work colleagues, both in like almost every specialty in the hospital. And it's not just pediatrics. Like, although for me, I do about 75% pediatrics, about 25% internal medicine. So I have colleagues that do more internal medicine, more of the internist, and you will still interact with all those specialties. There's numerous opportunities. And I think that there's one thing that you have to know about genetics is it is such a big specialty. There are so many things you can do. You will never feel limited, So this is my son, actually, as we climb to the top, one of the Dolomites, which if you ever have a chance to do this in your life, you should. It is the most grueling hike on the planet. But as you can see, the views are spectacular. He looks substantially better than I do, which is why you have him there and not me. 16 goes up a mountain straight up better than 40 something. So, but it is the sky's the limit. You can do general genetics. You can be highly specialized and be like Brian and be like a world expert in Down syndrome. We have people who have or specialists in certain inborn errors of metabolism, but you also can do more broad things. I do some general genetics. I do some biochemical genetics. I don't do molecular genetics, but I have colleagues who have said, I really like the lab part more. So they ended up going to lab parts. One of my colleagues is a prenatal specialist, right? So you have the opportunity to specialize And those specializations kind of lead to a lot of the research you'll do if you want to do that. But you also can be a generalist and you can just see everything. So there are the opportunities there, the opportunities for growth, the opportunities to define your own pathway are really special for genetics. And I think in a way, you don't get pigeonholed the way you do in some specialties. I love the fact I get to teach. I get to teach all the time. I love working with the residents and the medical students. The residents are always nice and give me a little teaching award every year, which is kind of fun. But I've taught at all levels. I've gone to family groups and I've taught at family specialties. I've spoken at national meetings. I've done CME conferences we have here. You know, I have the medical students rotate with us. I do residence lectures. I do a lot of stuff I do stuff for the cardiology fellows and the PICU fellows and the HEMONC fellows. So there's a lot of opportunities to teach. And again, these are opportunities. Not everybody does this, but that's one of the things I really like. The students keep me young. They ask me good questions. They challenge me to think. They teach me new things. And it also keeps me, so I keep abreast of what's like going on in general pediatrics and what's going on in general medicine. So it's really a two-way street that I think is really special for genetics. And again, because you have this kind of niche thing, people are always asking you to teach. So there's a lot of opportunities. This is what it's a small collegial, national, and international group of fellow geneticists. I think genetics, you know, because particularly, I mean, for metabolic geneticists, where there really are not a lot of us. I have never in my entire over decade, and that doesn't even include like, you know, fellowships and stuff like that, have I ever picked up the phone and called them? I don't care if they're like the expert of the expert, the super subspecialist. If I pick up the phone and call someone, they pick up the phone for me. Like they talk to me, they help me. There's something called Metabel where we kind of go back and forth and get help. We'll write collaborative papers sometimes across like multiple institutions. Like it's a diverse multicultural community. Like I interact with people in different countries from all over the world, kind of come here to do this. And I always feel supported. There's not, you know, sometimes you get in a lot of these kind of, some parts of medicine, these kind of institutional turf wars about things. And I'm sure there are politics like there isn't anything, but not as much in genetics. Genetics really has this feel of we're all in it together. Like it always feels like that. And I think there's this, you know, we all understand that we need geneticists, right? We need to get people in the community. We need to support one another. Our work is critical. Our families desperately need us and vice versa. Like the families give so much back to us that I love the fact that I feel like there's nobody in the community that wouldn't help me and support me if I needed it. There's work-life balance. And how much of this work-life balance you take advantage of is up to you. But you can have some flexibility in work schedules. And then there's also the ability to kind of practice clinically, and then people will kind of help you ramp up later on. So this was particularly important to me. My son had health problems when he was smaller, and I had to step back from the physician scientist track that I was in. And that became kind of what was important to me for a number of years. And then, you know, now that things are better and we've kind of moved out of that phase, like I have a lot of support for people helping me to kind of get back into doing certain kinds of research and stuff like that. If you are in a very, very traditional track and you kind of go straight through, you can also be very focused and get a lab and have everything from there and be in work as much or as little as you want to some extent. But there is more work-life balance in this. You know, I haven't missed, even though I think I work really hard, I try to take really great care of my patients. I also feel like I feel like I can take great care of my patients and be doing all the stuff that I want to do for them, but still make it on time to catch my son in a play, or, you know, to be there when my mom is sick or something like that. So there is that, which I think is really important. And call is manageable. We're not cardiologists. We're not being called in for, you know, someone having a heart attack or a baby who's in heart failure, or a surgeon who's being called in to take an appendix out like day in, day out for months and years and so on. So yes, there are emergencies that we sometimes, if you're a metabolic geneticist, you're a general geneticist, not so much, but even those, they're farther and fewer between than they are in some specialties. And then this is actually my favorite slide. People really are impressed with what you know. You kind of have this niche thing. I kind of took this from when I was a medical student. I had this this anesthesiologist was really gung ho to make me become an anesthesiologist. And he said it's like, it's like being an anesthesiologist, when you run upstairs to a code and no one else gets the airway, it's like he's like pretending to rip off his shirt. It's like being Superman, right? Like everybody's there and you're doing that. I feel like that every day in my job. People, something about rare diseases. I think that Julie brought up, people don't know about rare diseases. So they're so happy to have your knowledge. They're so good about interacting with you. You're providing such a critical role in the team. That I love the fact that I feel very fulfilled by that. The families appreciate what we do. The families feel bonded to us because that the providers doing it. It really is a good thing where we're giving and we're getting back in the same way. So I feel like there's a lot of nice synergy there. And the most important reason is I still love my job. Years and years after doing it, it is always fun. I love the people I'm working with. Yes, we work hard. Yes, we have a very serious responsibility. We take really great care of patients. We're micromanagers. We're very meticulous in what we do, but we can do that while still having fun, being engaged, and feeling fulfilled. So I hope that, I hope more than anything, you realize the enthusiasm I think a lot of geneticists feel for their job, and I think it's something really you should consider at least rotating and learning a little more about. So thank you very much for listening, and I will turn it over to the next person.
All right. Thanks, Michelle. Wonderful. All right. On to our third speaker, Dr. Jerry Cox. Dr. Cox founded Gerald Cox Rare Care Consulting in 2018 to assist small biotech companies in their development of drugs for rare genetic diseases. He's a 20-year veteran of the biotech industry and a practicing clinical geneticist for over 20 years. He's consulted in a number of disease areas: metabolic diseases, muscular dystrophy, neurologic diseases, immunodeficiencies, and using a number of therapeutic approaches, ranging from small molecules to biologics and genome editing. He often serves in a chief medical officer role at these companies and provides strategic advice on disease targets, clinical development, and regulatory interactions. He began his industry career in 2000 at Genzyme. During his 16 years there, he led the clinical development programs for enzyme replacement therapy in the US or elsewhere for several lysosomal storage diseases, including Hurler disease, Hunter disease, and Gaucher disease. From 2016 to 2018, he was chief medical officer at Editas Medicine, where he oversaw clinical development, regulatory affairs, and scientific communications. And he was the medical lead on the first US IND for an in vivo delivered CRISPR-based medicine to treat Leber congenital amaurosis type 10, the most common cause of genetic blindness in children. This past September, one of his clients, a China-based rare disease company, received regulatory approval in China for enzyme replacement therapy for Hunter syndrome. He's a board-certified geneticist, clinical, biochemical, and molecular, who continues to see patients part-time at Boston Children's, where he was previously on full-time staff and completed his pediatrics and genetics training. He's an instructor in pediatrics at Harvard Medical School. He received his MD, PhD from UCSD in 1989, a BA in biology, magna cum laude from Harvard College in 1980. He has over 80 peer-reviewed publications. In 2019, Jerry joined the board of National Tay-Sachs and Allied Diseases Association, where he leads their strategic research initiative. He was founding member of both the Pediatric Cardiomyopathy Registry and the Barr Syndrome Foundation, and in 2020 joined that foundation's Gene Therapy Advisory Board. Tell us more, Jerry.
What's left to tell? Thanks for that introduction, Mark. Some of you may or may not know that Mark was actually my mentor when I was going through my training at Boston Children's, and so I'm really happy to be able to speak.
All right. It seems we lost contact with Dr. Cox. He's signing back in. So I thought maybe we do a couple of questions. Although, so Brian, we'll ask you a couple of questions while waiting for Jerry to come back in. Do you work with genetic counselors? And if so, what kind of work do they do? How does your work compare with theirs?
I do. So in addition to being a doctor in the Down syndrome program, where I don't work with genetic counselors, I also am a clinical geneticist a couple of times a month, where I do practice with genetic counselors. And they're so important. So the genetic counselors will oftentimes gather information ahead of time to make sure it's a good patient experience. We will review our patients ahead of time and say, okay, what labs are we thinking of ordering? And maybe we need to get this information. And Brian, let's think about this. And I'm thinking about this diagnosis. And then with the genetic counselor, I ask them in the patients we're seeing that morning, which patients do you kind of want to see first and own? And oftentimes those will be patients where there is a lot of education that needs to happen, a lot of discussion of results, a lot of explaining what chromosomes are and how they work and what the results are. The genetic counselor will go in first in order to have that conversation. And then I'll be brought in at the end in order to do a physical exam, in order to order any medical tests. And then together we have a conversation and what do we need to do next for this patient? So it is great working with the genetic counselor, and then between visits, the genetic counselor is an invaluable partner in order to respond to questions, follow up on lab results, and of course, do all the prior authorizations that we hate to do that are necessary in order to get some of the testing done in our field.
All right, thanks, Brian. All right, Jerry, let's go back to
I don't know what happened there. Were you all on the connection? Was it just me?
Yeah, we stayed.
Okay, so back to medical school. So I remember taking a class where it was a little boy who had a rare condition called xeroderma pigmentosum, where his DNA was unable to repair itself properly. And so his body was prone to mutations and skin cancer. And he needed to shield himself from the sun. And this is living in San Diego, which is pretty difficult. So he walked into the classroom wearing a long sleeve shirt and brimmed hat. And, it was really sad to see, what effect, a single genetic change, had on this boy's life. So I decided I really wanted to continue in pediatrics and genetic diseases and try to make a difference for these patients with rare diseases, which, led me to Boston to complete my pediatrics and genetics training. And again, I was thinking I would do that for the rest of my life when I had an opportunity in 2000 to go to industry, which, is completely foreign to me. Some of you might know the famous Yankee baseball player Yogi Berra, who is famous for saying, when you come to a fork in the road, take it. So, a lot of times in your career, you'll be faced with situations that you could never have imagined. And I certainly never thought I would go into industry after all this training at age 41, but I did. And it was really an opportunity for me to develop new treatments for children and adults with genetic diseases that really had no treatment and that were suffering. But combining, the scientific understanding of the disease with a treatment approach that matches up with being able to reverse disease symptoms, really became very gratifying for me and for several years, I worked on lysosomal storage disorders where different diseases are caused by different enzyme deficiencies. And with the recombinant DNA revolution having occurred 10 years earlier, we could literally make any enzyme that someone needed in a bioreactor and then give it back to them, and their disease would melt away or reverse. And it was incredibly gratifying. And people would say, well, don't you miss taking care of patients? And I actually enjoy taking care of patients. I continue to do that part-time, but the way I rationalized it was I kind of gave up, seeing individual patients with lots of rare diseases to really taking care of whole populations of patients with one disease. And even though they're pretty rare, there might only be a few thousand patients in the US or the world. Working at biotech companies is very different than working at big pharma, where you're taking care of or developing drugs for millions of patients. You never get to know them. And in rare diseases, there is that small community, like Michelle was mentioning, not only among your colleagues, but also among patients. So, the company I joined right out of academia was Genzyme, which had a really patient-centric approach. And it was really a natural fit for me because I got to know the community in all these disease areas. Patient advocacy groups were springing up, and they would bring us in touch with patients. We could talk to them about their disease. And just like that little boy that, couldn't go outside in the sun, for fear that he developed these skin cancers, probably for him, it wasn't so much developing skin cancer that was on the top of his mind. It was probably on the top of his parents' mind, but it was just going out and having fun. And so, when we develop treatments for diseases that have never had treatments before, it's a blank page that you start with. And, my job in clinical development is to design a clinical trial to show that the drug, is having a clinically meaningful benefit to patients as well as being safe. And so a big part of that job is, reading the literature about these diseases, interviewing physicians who take care of these patients, but most importantly, speaking to patients themselves to find out what really matters most about the diseases. And if, there was to be a treatment developed, what would they want it to do to improve their quality of life or improve their health? So, I've really enjoyed my time in industry. It's very different than being in academia where, as a physician, you have your own patients. And a lot of us, that practice within an academic department, we're like 3-year-olds who play in a sandbox, where we're all taking care of our individual genetics patients. But in industry, you work on teams, and your various team members all have different areas of expertise. We have people who specialize in interacting with the regulators. We have people who specialize in statistics. We have people who specialize in setting up clinical trials at different academic sites. And so there's a real mix of expertise. So I'm always, feel like I'm in a learning situation, which is, I think for certain people, that's what really motivates them, is realizing that it's okay that you don't know everything right now. Genetics is a constantly changing field, and, families would say to me about their child, is there a treatment, available? And I might have to say no, but I'd say come back in, a couple of years and let's talk again, because the field moves that quickly. And now with not just enzyme replacement therapies, but now we can actually manipulate DNA, and there's all different forms of genetic engineering that can lead to gene therapy or genome modification. Diseases that we never thought we could treat before are now treatable. So to be in a situation where, you can actually make a big impact in a particular rare disease population is, what drives me every day. And I've now gotten to the point where, having worked for, single companies for 18 years, I branched out on my own, Rare Care Consulting, and I get to work with a lot of former colleagues from Genzyme that have all gone on to different companies that are bringing in new technologies to address diseases, where the patients are still suffering. There's more than 7,000 different rare diseases that we know of, and there's treatments for only about 5% of them. So, there's a huge unmet need in this population of rare diseases. And I'm just very happy to be able to continue to contribute across the board for many companies that have all picked these individual rare diseases to develop treatments for. So I think I'll stop there.
Thank you, Jerry. Actually, I'll just ask a couple of questions. So you have a computer science background. What computer science opportunities are there in genetics or bioinformatics, data science opportunities? Can you address that?
Yeah, so in industry, with a computer science background, there's a lot of bioinformatics or data mining that we do. We have statisticians that often have computer science backgrounds that enable us to learn more about diseases by understanding what the different clinical signs and symptoms are, through registries that we set up, through insurance claims databases. That involves a lot of programming. I think on the science side, there's a lot of genetic, I would say, different genetic variations that can cause disease through different mechanisms. And people are using artificial intelligence now. In fact, one of the companies that I was consulting for, Deep Genomics, was applying bioinformatics and deep learning to understand the molecular basis of different genetic changes and how, based on that mechanism of action, how you might think about designing a drug that would correct the effect of that genetic change. So I think, there's opportunities both on the science side as well as in the clinical epidemiology side. We have people from public health that get public health training that join companies. There's a lot of epidemiologic data mining that occurs. So it's really, a variety of, I think, applications for a background like that.
Thanks, Jerry. Michelle, can you unmute? What kind of training did you do after medical school in terms of residency, fellowship programs, and what kind of specialty training exists for genetics?
Well, so I can tell you my pathway, but there's actually multiple pathways. So I started in internal medicine. I completed internal medicine residency, and I did all my training at Duke. So I did my internal medicine residency at Duke. Then I did 2 years of general genetics training, and then I did another year, kind of like 2 years of biochemical genetics training. You can do biochemical training in 1 year, but because some of the other my interest in neurogenetics, I did an extra year so I could do some extra time in neurogenetics. So that's the pathway that I took for that. For genetics, you can come actually now, I mean, they've even become more flexible in what you can do. It used to be that you could do either most people came out of pediatrics, second most people came out of kind of internal medicine, and then family practice and OB were the kind of pathways in there. But now we had actually someone who actually wanted to come to us out of surgery recently. They decided they want to be surgeon. They love genetics, and that's where they came to us. So there are options once you do your general training, but probably a general specialty like pediatrics, family medicine, internal medicine is probably the best training to kind of make the transition.
Okay, and just following along that, going back to basics, can you explain the difference between biochemical, molecular, and clinical genetics? And is the training different for those?
So it is. All geneticists are clinical geneticists. So when you complete whatever your primary specialty is going to be, so whether it's pediatrics or internal medicine, the first 2 years afterwards are general genetics, and that's where you learn everything in general genetics. You do various rotations. You'll do some time in like clinics where you're doing more dysmorphology and intellectual disability, autism, things of that nature. And dysmorphology just is kind of a way that we look at facial features and abnormalities and way things are formed in fetal life that helps us make a diagnosis. And then, but you'll also rotate through the metabolic genetics, which I'll talk about in a minute. You'll rotate through some of the labs. So the general genetics is kind of almost like, it's like really doing another residency, but this time you're focusing on genetics diseases and you learn everything. People who kind of stop at that point frequently do it because they want to be more generalist. They want to see a variety of different diseases. They generally don't take care of metabolic genetic patients, biochemical, although some do because there is training in that as well. People who are really interested in inborn errors of metabolism, this was kind of the pathway that I took, is they can do one of two fellowships. You can do a clinical biochemical fellowship, and that is as short as a year. You can do more than a year if you want to kind of further subspecialize within that, or you can do what they call medical biochemical genetics. I did medical biochemical genetics because I was more interested in seeing patients, and that is a more patient-oriented, kind of clinical translational research-oriented one, where I further spent the whole time, all that time, just seeing patients with inborn errors of metabolism. So all that stuff that's on the newborn screen is part of that, but also like mitochondrial disorders and lysosomal storage disorders. So some of these cool things that Jerry's making kind of treatments for, we're the people then who then go implement the treatments, which we're super grateful for, to be able to offer that to families. So that's kind of like the next step of that. Or the people who do clinical biochemical genetics can still do, what do you call it? They still will practice clinician, but they're more lab focused. They go into the lab and actually read the tests that help us determine what kind of metabolic disorder the patient has. We have all these tests to see how people are making energy, how they break down proteins, carbohydrates, and those kind of tests help us make a rapid diagnosis so we can do rapid treatment and kind of really save brain cells, save babies. And then molecular geneticists, again, usually have completed their 2 years of general training, but they're more focused on the DNA lab. They're doing exome sequencing or single gene sequencing and all that part there where we actually, again, really important colleagues. I think the recurrent theme here is we all work together as a team, but they go in the lab and kind of help us determine what gene has a mutation in it. So then we can go back and give the family an answer and kind of provide them with the correct diagnosis. And again, a lot of people divide their time between the lab and clinical, and how much you do that really depends on your individual interests.
That's actually a good point, Brian. What portion of your week is dedicated to research and what portion to clinical hours? What determines this and how do you manage that?
So I would say right now I probably spend 20% of my week doing clinical care, and I would say other 80% is mostly split between research and administrative responsibilities. The research time is really defined by whether or not you have funding to be able to do research. So when you see patients, the clinical revenue from insurance is going to the hospital, and that's paying for your time seeing patients. When you want to do research, you need someone to pay for your time and salary to do that. And that could either come from small grants, big grants, nonprofits, chairs, lots of different ways to do that. I have been fortunate to have various different grants throughout my career, but I have to say there are sometimes I have more grants and sometimes I have fewer grants. So that means that those of us who want to have some research factored into our lives, we also have to anticipate some salary fluctuation, which I've experienced over time. The nice thing is if I were to have all my grants dry up, I could continue being a doctor and seeing patients and being able to see more patients. But right now it's about a 20-80 split.
Okay. Jerry, is personalized medicine for all or most a realistic treatment option in the near future? Oh, you have to unmute. Jerry, unmute.
I'd say, essentially all the treatments that we have for rare diseases by definition are personalized, where they would treat an entire disease population, for example, enzyme replacement therapy, or, for a lysosomal storage disorder, or like a gene therapy for blindness. But I think the next wave, is what you're probably really referring to. It's almost like the individual personalized medicine. If someone has a specific genetic change that is causing their condition, could someone whip up a treatment in the laboratory for that specific patient and then treat them? I think the way the system is set up, the way that drugs are approved are done through clinical trials of groups of patients. They're not done on individual patients. There are some celebrated stories that you might hear about. Even at Boston Children's Hospital, there was a little girl that had a specific genetic change causing her condition, and one of the staff geneticists decided to make treating this specific child, his mission. And so he wound up designing essentially a personalized medicine for this girl, which he did eventually get through the FDA and treat the child who has stabilized in her condition. But I think the system isn't really set up right now for that. We're still talking about groups of patients. I think within a particular disease, there might be some common genetic changes that might be amenable to a certain type of treatment. Even if it's 10% of the population, of the patient population, or 20%, that's still meaningful for those patients. I would like to see the day where someone comes into a genetics clinic, they have whole exome sequencing, their genetic changes are identified, and then you move on to a treatment clinic where they design a personalized treatment for you. But that's still, I would say, really in its infancy on a patient-by-patient basis.
Thanks. Michelle, how often do you come across patients who have genetic anomalies or symptoms with no answers? And how do you handle them?
Yeah, so that's a great question, and probably one of the harder ones to answer. So quite a bit still. So I would say, our diagnostic rates in our clinic are probably 30 to 40%. And I think that puts us in line with what most places are throughout the country. It depends what certain diseases we have a higher rate of diagnosing, but certainly not everything. And that probably, people always ask me what the hardest part of my job is, and it's not even giving the bad news where we have a very clear diagnosis. I think this is the hardest thing for families, right? And it depends where they are in their kind of journey through things. But the problem with not having a diagnosis for families is it leaves them with a level of uncertainty. No matter how hard something is, I have to tell them, knowing what it is, knowing what can and can't be done, having some clarity of what the future brings, I think gives people closure. Having a child, and this is most of the time with having a child, but sometimes with adults who have complex medical illnesses that no one has an answer for, I think is very scary. I think is very frustrating. So, what I have done over the years, the first thing I tell families is, even if we don't have an answer now, I'm still your doctor. I'm still going to take care of you. I'm still going to be here for you. We're in this together for as long as it takes. And I said, until I retire, I'm going to keep looking for an answer for you, trying to find you an answer. And so that's it. And I tell them and it's not uncommon. If I don't find it today, I always say, if I don't find it today, I'm never going to find it. Right. So that's number one. That's one of the things I do. Number two is we still try to treat the things that we can treatable. Even if I can't give you a name for it, we still try to manage the symptoms. We try to make sure the support from school, letters you need, subspecialists you need. So that's, so making sure that they have the support. Three, and this is true, I think this is not just for an undiagnosed, but maybe a little more important, that making sure they have access to you. I think so often undiagnosed patients feel like, they have no home. So kind of giving them that kind of home, I think is really important. And I think just helping them verbalize and making it okay to verbalize their feelings around this and the fear around it and the frustration and stuff, and making them feel supported. I think are probably the most important pieces for that.
Thank you. Brian, advice for getting involved with genetics if you're an undergrad or a grad student, and what should I study in grad school?
think there's two parts of that. One is content and one is experience. So I think if you are an undergraduate, you might say who in your local area is a practicing geneticist and reaching out to them and saying, hey, would it be okay if I were to observe or shadow in your particular clinic? I think most of us really do, whenever possible, welcome students to be able to shadow. I know during COVID times, many hospitals do have observer restrictions in place, but soon we will get through this COVID pandemic together and there will be opportunities for people to observe. So no better opportunity than I think to see a living clinic in practice and be able to do that. The next thing, in order to, what do you want to learn about? I think in a kind of a trite way, everything relates to genetics. So no matter what you study, I remember one of my greatest classes in undergrad was an Art History 101 class. And I tell you, if you stare at a lot of those paintings at the Museum of Fine Arts in Boston, you're going to find a lot of genetics on those walls, right? So that's genetics as well. Reading the humanities, I think, allows you to become a better doctor and more well-rounded. Learning rhetoric, I think, will help you write better patient notes and be able to help write research papers. I think taking poli-sci classes allow you to better understand how humans work. So when you're in a faculty room and you have to realize everyone needs to get along and how do you work past differences, that makes a difference as well. And then there's the science itself. And as an undergraduate, Michelle, I went to Duke as an undergraduate. There is a Down syndrome clinic there, and I contacted the director of the Down syndrome clinic, who's now become a good friend and colleague to me. And I asked, can I shadow you in your clinic? And I said, is there any research I could help you with as a little undergraduate? And I got to pipette, I got to do a couple things, made me feel like $1 million bucks, but I also dipped my toe in the genetics pool. And so there are research projects as well that you could be involved in. So I would say, see what's available in your local areas and don't be afraid to knock on doors.
Great. Folks, just give us we started a little bit late. Give us just a few more minutes. We're going to take 2 short questions, and then I want to go over opportunities that you can look at for more experience. Michelle, you came at, most geneticists train and come from pediatrics. You came from internal medicine. What do you think? Medicine, pediatrics, what's the better path?
Yeah, the first thing I'm going to say to that question is you should pursue what drives you, right? So at the end of the day, you're going to be spending a lot of time doing a job. I think that they're all great trainings: medicine, med peds, internal medicine. If you have a particular interest, you should do that interest. I think the most important thing is to go to a rigorous program that's going to give you good basic training, because I think, again, a recurrent theme that I think everybody said here is genetics is everything. It really is. It encompasses all the organ systems, so many different things. I think getting good, broad-based, challenging training is probably the most important thing. And whatever pieces you're missing, you're going to kind of fill in. I mean, like I said, even though I started life as an internist, I see 75% of children. I have gotten really good at, calculating things for babies and understanding a lot of pediatric diseases and even how to treat basic pediatric diseases. I mean, I'm not quite sure I would be able to treat Kawasaki's, but almost anything else I feel like I have. And people are going to help you. I mean, that was my experience too, is that whatever pieces I needed to fill in, and everybody needs to fill in something when you come into genetics, because there's just, again, it's so broad. People were there for me. Everybody, you explain to that, you learn on the job, and it's it will be fine. So pick where your heart is taking you, and then the rest of your career will kind of come from that.
All right, Jerry, answer one of these 2 questions. What is a great piece of advice you wish someone had told you sooner? Or what is something that they don't teach you in medical school?
Well, I certainly didn't know about industry when I was in medical school. At that time, it was called the dark side, because no one went to industry. I mean, everyone in industry was screening soil samples for rare, compounds produced by fungi that would treat some disease. And so for me, having the opportunity to go into industry where you could actually apply, rational design to treatments instead of just, fishing through soil samples was really an important step, I think, to apply, the scientific understanding of DNA, RNA, and proteins, and how we can design drugs at those different levels using different approaches to treat human disease. So I had no preconception about going into industry, but I never looked back. It was a great decision for me, and I think like Michelle and Brian have said, is true. You have to keep an open mind and find your passion, and then don't waver from that. There's going to be opportunities that come up that you could never have imagined that will take you in a direction that's very fulfilling. So, keep an open mind, go in a general direction that interests you, and then, let the fork in the road, take you where it may.
Great. All right. On to the final part of our, the final part. And that's the opportunities that are open. Can you see that, the additional learning? Okay, terrific. So things that you can do. One is if you want to have a one-on-one conversation with a geneticist, a particular person, a particular branch of genetics, we can help arrange that for you. It's an opportunity to focus on your interests as well as to ask more about their career. Two is if you go to the American Society of Human Genetics website, they have printed interviews there, researchers who talk about their important scientific findings, their career journeys, interesting things that they have contributed to science and to medicine. On-site electives, it's an opportunity to shadow a geneticist. Right now, it's probably a little bit more difficult during COVID, but it is an opportunity to see what goes on in a genetics practice. Let us know if you're interested. When all this is over, we might be able to arrange something for you. We do recommend a letter of intent and a CV, having that ready. In the meantime, we are putting together some online electives, so online counterparts to the in-hospital shadowing experience. In an hour, we'll watch videos of patients who are talking about their experience of living with their diseases. And then we talk a little bit about the science, about the medicine, about the impact on those patients and their families. We have two scheduled, January 21 in association with Bay Path University Genetic Counseling Program, and RNE is hosting one on February 10th. RNE also has a Rare Disease Day speaker series in which we are going to 11 medical audiences around the New England area between January and March, since Rare Disease Day is the last day in February. So we're going to all 6 New England states and going to hear patients who are talking about living with their disease. It's a longer program than the elective. It's an hour, but it's just one patient. And we go over, we review the disease first, and then we hear more detailed description of what it's like to live with that disease. Finally, there's the American College of Medical Genetics Foundation Summer Scholars Program. If you're in first-year medical school, you can apply for this, and you can be enrolled in a 6-week elective experience after your first-year medical school. Applications are released the middle of this month, and the due date is middle of February. And finally, Global Genes, which is an umbrella genetics organization, they have a compassion project. If you want to be linked to a patient or family with a genetic disorder, applications are accepted year-round, but matches are quarterly. And you're given time to help feel out what it's like for a patient and family to live with a genetic disorder. At the completion of that, you would be eligible to submit an essay for the David R. Cox Scholarship. So at that point, I want to close the session by saying thank you so much, for our panelists and sharing with this group your passions. because that's what drives all of us. I want to thank RNE for making this happen. And attendees, thank you so much for staying with us. I would ask you, do us a favor and complete, we're about to just give you a very short evaluation. So please complete this poll before signing off. Thank you so much. Have a great, a safe, healthy, and happy holiday season.